So adding anti-angiogenic therapy in the first-line setting, and this would really be restricted to bevacizumab, I think there are several benefits. First and foremost, what patients want almost universally is their tumor to shrink. And we know that adding bevacizumab to chemotherapy, and this has been consistent across 4 phase 3 trials done all over the world, is that adding bevacizumab to chemotherapy increases overall response rates significantly. The other thing patients want is control of their cancer. And in all of those 4 trials I mentioned, there was an improvement in progression-free survival that was statistically significant. And I actually think in an age where we talk about not only statistical significance, but clinically meaningful benefit, I actually think that the overall response rate is very clinically meaningful. The PFS is also clinically meaningful, although a little less robust. And then patients want to live longer. And in 2 of the 4 trials, we saw a survival advantage. Those were 2 trials that were designed to look at overall survival. So I think that that's the third benefit that patients get. Now, it comes at a risk. If we add anti-angiogenic agents to chemotherapy, we do increase the risk of certain side effects, higher rate of neutropenia, the risk of febrile neutropenia, hypertension, effects on the kidney with proteinuria. You have to be concerned there's a numerical increase or in thrombotic events, so you have to be aware of these sorts of things. And you have to be aware that you do expose the patient to more risk in choosing an anti-angiogenic agent. But I think if you're thoughtful in patient selection, that anti-angiogenic therapy has much more benefit than it has risk.